The views and opinions expressed on the Nurses Station are those of our hosts and guests.
Not necessarily the views of Emory University,
the Nell Hodson Woodruff School of Nursing,
or Emory Healthcare. Enjoy the show.
Hey everyone, welcome back to the Nurses Station. This is the place where nurses come to dish some real chat and sometimes eat and drink, but we're not going to do that today. We've already talked about it. You're welcome. As a reminder, this is our show we're distributing every other week this fall, and we just want to thank you all so much for the support already with the views and the comments. It's great to see you again, and we're glad you're with us. You can find us, as a reminder, on www.nursing.emory.edu/nursesstation, or wherever you listen to podcasts on Apple, Spotify. We're on all the socials, Facebook, Twitter, Instagram. And if you want to extend your experience a little more, join us on a LinkedIn group where you can actually get our show notes and have some discussion with us. It's helpful if you actually subscribe or follow us, so then when new episodes come out, you'll be alerted to those. Today, we're going to take on another topic that definitely affects us as professionals and as clinicians and educators, and that's the topic around immigration. And so this is also, of course, the year of COVID, and we're going to talk a bit about the intersection of those two things. So I'm going to invite our group today, Dr. Tim Cunningham, Dr. Lexi Dunn, and Dr. Roxana Chicas, who are going to join me today in talking about this topic around immigrants and immigrant health, which has been, I think, even more so on everyone's mind in a time when we are dealing with this pandemic and as a group that is disproportionately seeing the effects of COVID-19. And Roxanne, I know you spend a lot of time in this space, and so I'm going to invite you to have the first word.
Yeah, so what comes to mind to me right now is that, I don't know if you've seen all these pictures coming from California where agricultural workers are working and like the sky's orange because of the wildfires. And many of them, their employers are not getting N95 masks. And so grassroots organizations are passing those out to workers. But can you imagine to be working outside in the heat, having smoke all around you, working where you're bending constantly, back pain. Many of them do not have access to healthcare. It's really just startling to know that we still have a workforce that's pretty much invisible, and yet essential, yet we don't take care of them very well as a society. And so it's really hard. And in addition to that, there has been this public charge rule that came into effect. And there has been a lot of misinformation amongst the immigrants in the United States on what this public charge rule means, and the implication that if you go and seek healthcare, that might affect you later on in life if you are able to adjust status. And so many families I know have decided that they're not seeking healthcare, they're not seeking any type of benefits for their children because of this fear that it will affect them later on in life. It's really remarkable.
Wow. And, you mentioned the N95s or just PPE or any type of protective equipment that you typically need to do your work. And we're having this severe shortage. And we've had a number of conversations and a lot of press and attention shown to PPE shortages for healthcare workers. But this population is not necessarily on the radar for priority access to that type of equipment.
Right. But, there are organizations trying to help. And it's not just agricultural workers. There's a lot of other workers in the service industry, part of the food supply industry, like poultry workers who have been impacted by COVID-19 very also. So, and like many other people in this country, there's people don't want to go into doctor's offices or hospitals because of the fear of COVID-19. And for immigrants who don't have health insurance or access to health care, it's really hard to balance continuing to work because you're a part of the essential workforce and also not to get sick so that you don't expose your family, community. But did you say PPE, Carolyn?
Yes, I said PPE. It's been talked about so much.
It's about time you got a dollar in the bucket. You've been just being all perfect all these episodes. It's about time.
So to catch you all up, those new listeners who are trying to figure out why Carolyn's a little upset right now, is we play a game on this podcast. It's an acronym game. And if someone says an acronym like PPE and doesn't describe what that stands for, they have to put a dollar in the pot. And at the end of the season, we collect the money. And I think we're giving it to me. But that's yet to be decided.
We probably should, since you're putting the most money in so far.
Wow, I've not lost any money in this episode. So.
Wait, there was something in the last episode. You said fMRI.
Oh, I did say fMRI. I did.
See?
Yeah, but I don't know. Going to get away with it.
I don't know if any of you recall the subtext and in the contract we signed that anything recalled from a past episode doesn't count in the present episode because you didn't pick it up in the last episode.
No, but we did pick it up, and it was such. We had the ANA president. I mean, the American Nurse Association president. Don't you even start. You didn't even chance
dollar right there.
No, you didn't give me a chance to pick.
Roxanne, it looks like you're the only person who's not losing money so far in this episode.
Yes.
Back to the conversation.
We can do something about this.
Yeah. Hey, Carolyn and Roxanne, I was wondering, as we think about our members of the immigrant communities who are essential workers, who are doing this work, who are at risk, and then other folks who have healthcare, who are not worried about their jobs, when they say things like, why should that be my business? Why should I even worry about that? And I think as nurses, especially from a public health standpoint, how do we show people, and maybe the research is out there and I just haven't seen it, that by not getting people access to care, we see higher risks of other disease spread, right? We see higher risk of other outbreak. When a person is sick in this country, if it's not me, it still affects us all as a community and a country. And like, are those messages getting out so people understand why it's important that everyone has healthcare? Or is that some work that nurses need to do?
I think Lexi made the point before about this notion that mask wearing protects people around you, not yourself. And that's one of the reasons, but not the only, that you would have hoped COVID-19 would show all of us this exact principle, that other people around you being sick, still your problem, right? That we really need to think about each other. Yeah, Lexi, say more.
I mean, yeah, if we want to keep taking this individualistic approach and think that we can just leave out a whole population of people, that's just a wrong way to look at it. The health of one person impacts the health of the nation. So until the nation can look at it that way, we won't be a healthy nation. When I think about immigrant health, I think people just push it to the side like it's not important because they want to just focus on the status quo in the mainstream. But when you have people that live in a country in fear, and because of that fear, they are not accessing the healthcare systems. They are not coming to seek care when they need it. That's a problem because I don't think immigrants are inherently unhealthy. I think because we focus on immigrant health and the fact that by the time people interface the healthcare system, they're far advanced in their illness, the presumption is that these are unhealthy groups of people. And that's not the truth. The truth is many people come to this country, they're trying to find a new life. They're trying to get out of unsafe situations, and they are healthy. But once you come into a country that doesn't have anything set up for you, that has you in fear for whatever reason, then you're not going to access the care and get the needed preventative things that you need in time. And then you develop disease. So to me, I feel like it's a consequence.
Absolutely. Well, and if you want to think about what it means when someone around you, other people around you are essential workers, not benefiting from many of the worker reforms or the CARES Act. And I'm just going to throw the dollar in right now because I can never remember the full acronym of that I give. So let's think about the long-term care workforce. So 1 in 4 workers in long-term care settings, which of course is our highest mortality rate from COVID, these frail elderly people residing in those settings. 1 in 4 of those workers was born in a country other than the US. So whether they have legal status or undocumented, working in that industry right next to, so you have a high risk population in terms of inability to access care potentially, who've been disproportionately affected, next to this group of patients that we're all paying such close attention to and ignoring the fact that that workforce really has to also be prioritized if you want to focus on the health and well-being of that patient population. You cannot separate those two. Tim, I think about all of the, how do we prioritize workers, including our colleagues who also were born in a different country, who are immigrants, because they face a number of challenges in all of our healthcare settings, not just in long-term care.
Yeah, I think when we look at sort of social aspects of our colleagues who have immigrated from another country. I recall a technician that I worked with when I was working in New York City. And this gentleman was actually a physician in Syria. When the war started, he and his family moved to Poland. He didn't speak Polish. He learned Polish, went to med school in Poland, became a physician in Poland, and then brought his family to the US. And working as a technician in our emergency department, his role was to move patients from the ER, the emergency room, to a scanner, the X-ray, the CAT scan, bring them back. It was his job to run electrocardiograms, EKGs on patients. It was his job to draw blood on patients when doctors ordered it. And he was the wisest person in our unit. And I said, how come you're not a physician? And he said, because of the rules and regulations and laws of this country, I would have to go through a whole other residency again, which is hundreds of thousands of dollars, tons of time. And he was telling me this story. And then he said, but Tim, the knowledge knowing my kids can play in the street and not step on a landmine is all I need to know to make $17 an hour to do this work and provide for my family. And yet, one thing that we learned as a culture in our emergency department was when we had a question, when we had a tough diagnosis, we would all turn to him. Now, he wasn't writing the chart, but we would lean on him for his wisdom and knowledge. And we made good decisions because he was there. The shifts he was not there with us, things did not go as well. So I think culturally, one thing that we often ignore in healthcare is the wisdom that people that have immigrated to the US bring to the table, even if they're not practicing to the top of their role, because there's systems that prevent that. But I think, how do we ask those questions and recognize that wisdom comes in all forms and has nothing to do with the letters behind your name? And I think we need to continually do that, because we have some of the wisest people in this country have immigrated. I mean, if you look at entrepreneurs in this country going out of healthcare, some of the wealthiest, most successful entrepreneurs in this country immigrated to the US, or their parents did, and they're a first generation. I mean, we don't listen the way we should. And I think there's a lot of opportunity to do that in healthcare and beyond.
Yeah, that was a wonderful story. And I think that that's not the exception. I think that there's many immigrants who have the abilities to help in this country, especially like for nurses. Nurses, you talked about doctors, but there's nurses who come into this country who cannot practice because of those barriers in place in the system. And having a shortage of nurses, you would think that we would somehow create a streamlined way for nurses to come and help care for, our nation or our patients. So,
yeah, I would like to see more of those cultural perspectives on health infused into the nursing education process and into the hospital environment. I think that, again, we kind of have this American-centric model of what healthcare should look like. And some of the nurses I've worked with have been very influential in my progress of becoming a midwife. One of the first ones I worked with, her name is Pandora Hartman, and she's a Caribbean midwife. And I remember the way she did certain things in labor and some of the things she talked about, or some of the Caribbean African nurses that I talked to, the ways they were trained in their countries, honestly put some of our training to dust, because you really have to know information in a way, because you're not necessarily in a setting where you have other people around. So you really have to know what you're doing. So I would like to see more refugee and migrant health education, and even in the hospital. We talk about baby-friendly hospitals. What about refugee and migrant-friendly hospitals? Like, how can we, what can we put in place in the healthcare system to make it more friendly and more applicable to certain groups? I like to see stuff like that.
Yeah, I wonder about hospitals or health systems in agricultural areas. I wonder, Roxana, for people who participate in studies, or the populations that you study, what that would mean for that group if they had a migrant-friendly health system available to them.
I think they would love it. I mean, the study that we're doing right now is a longitudinal study. And our retention rate is really high. And it's mostly because since we're following them, we're doing, kind of like a lipid panel, checking their glucose, like a pretty comprehensive screening. And so it's like they see it as almost as a checkup that they can have like every 6 months to participate in our study. And so that's telling to me, because they do want to be healthy. They do want to access healthcare. And how nice is it when the nurse, who's me, speaks Spanish and can really understand where they're coming from. Like I said, I've mentioned before, I have lived as an undocumented person for 14 years. And so I really understand many of the struggles that they have and barriers in trying to be healthy. I mean, I remember when I was little, when I was 9 years old, I was diagnosed with toxoplasmosis in my eyes. And so I was 9 years old, and back then there was a lot less people who spoke Spanish in healthcare. And I was the one interpreting for my mom and the doctor. And somehow we navigated through that. But we did it. And I saw in one of the doctor's note once where he wrote of note, the child is the interpreter.
Wow.
Yeah.
Wow.
Wow.
That's, as we think about that, Roxana, I mean, because trust and especially trust that is established when someone speaks fluently another person's language, or like, what are ways that we can build trust with families when they come into the hospital if we don't speak that language? Like, I had this experience when I was working in a pediatric emergency department. I have very limited Spanish. It is not my role to be an interpreter because I'm not. But sometimes in emergency settings, there was no one on the unit, there was no interpreter available. And sometimes we might have like very specific tasks that we wanted to ask permission to do. So with my limited Spanish, I kind of looked up in a book the word to take, because I needed to draw blood on a young child. And so I asked the mother in Spanish, can I draw your child's blood? And I said, tomar sangre, which tomar is to take, but I learned very quickly, because fortunately I had another colleague who spoke Spanish that said, in that case, it also means to drink or to taste. So I was actually asking this mom, like, look at her, I was like, can I take or taste your child's blood? I quickly learned you say sacar sangre, but most importantly, I learned it's not my role. Maybe my role as a nurse is to find that person who can be there to be that interpreter, working with a family member if we have to, even though nursing regulations say we shouldn't. I think that's better than nothing. But then how do we work as leaders and policymakers to ensure that we have enough people in access? I mean, we're talking through Zoom. Why can we not have better technology to make sure we have trustworthy voices there for our families?
I will say telemedicine has introduced a whole another layer of complication trying to engage the interpreter on Zoom because of some of the restrictions. And so we've made it happen, but it has been, in some cases, when we know someone needs an interpreter, we have to plan for that a day or two in advance to set it up, because there's a part that has to come through the phone line separate from the Zoom room. Right. Still important. You absolutely want to make that service happen for that patient and their family, but you're trying not to, rely on them to be the interpreter. But it really is at another layer of complication, unfortunately.
Roxanne, I had a question for you.
Yeah.
So I appreciate you being open and sharing your experiences. I know it takes a lot to be vulnerable. In your opinion, what would be your advice to the nursing workforce or to nursing leaders about how we can actually truly address immigrant health? How can we make our system better? What are things that you've heard from migrant farm workers you work with or your own family members about their experiences here? Kind of give us some context on what is it that we should be doing better or how we can address it.
But I think that one of the main issues is trying to get more Hispanics into nursing. And because that really makes a difference when you can see someone else that looks like you and you can talk to them. And one of the other things is removing you guys may not know this, but DACA recipients, dreamers, are not able to get a nursing license in many of the states. Georgia is one of them. They cannot practice as an RN. And so they go off to these other states like California and New York where they can practice. And so, many of these DACA recipients who want to be nurses also come from migrant communities and rural communities, and they would go and work in those areas if they could practice as RNs. Mm-hmm. So I think that's one very important issue that if we could make it work, would alleviate a lot of the disparities that there are out there. I think that we also need some more regulations in place to protect workers, like agricultural workers. Heat is really dangerous when you're exposed to it and you have exertional heat, and yet there are no protections in place to protect workers, many of them who are immigrants, minorities. So there's that other layer as well. And I think that one of the things that nurses can do when you engage with, meet with immigrants, is like smile. It's like so easy. If you smile, I think most people kind of relax. And there's a warmth to it. And I think it's just something very powerful we can all do.
We talked about laughter too on a recent episode when it comes to burnout and resilience. And I mean, it sounds like smiling and then just laughing together. Yeah, could be another way to relieve some stress and build connection.
I mean, I think it's wonderful when, like you said, you were trying to speak Spanish and you fumble through it, and it's fun. And how nice is it that you're like making an effort to try to speak a different language?
Yeah, I've had my experiences in birth. I mean, I'm not nowhere poquito español. Okay, I don't speak enough, but I speak enough medical Spanish to get through a birth. And I agree. It's like I always tell them, lo siento.
Yeah.
Lo siento, poquito español, poquito. And, I always just kind of laugh with it. And so it's like, like you said, you set up that, like, I'm real. I know this has to be scary for you. I don't want you to feel like you don't have anyone on your side, especially if we have a family comes in, they're already scared. They may be in fear of deportation or discrimination because they know how this country, there are pockets of people that are anti-immigrants. I just can't imagine what that must feel like when you have to interface the healthcare system. So I agree with the laughter and just trying to find some kind of way to connect. I just try to find something to hang on to. So I agree with y'all 100% on that. Yeah. And you see how I fumbled through saying poquito. I couldn't even say poquito straight.
I had this great fumble. I remember I had a woman come in and she was with her child and she spoke Haitian Creole. And I knew one saying from reading about the history of Haiti, and it's like, "Wouche non soleil pas commun comprend wouche non de l'eau," which means the rock in the sun will never understand the suffering of the rock in the water. It's this like beautiful saying. And I was so proud of myself. I walk in the room, that's all I say. And then, we have an interpreter for the rest. And as I was about to leave the room, I totally forgot about this. She stopped and she said something to me in Haitian Creole, which I cannot remember and won't even try to pronounce. And I said, "Oh, thank you. What does that mean?" She said, "You look like a rat who's so tired it's about to die."
But it sounded beautiful, didn't it?
It sounded beautiful, and she laughed so hard, and her child started laughing so hard, and I was exhausted. I was having a miserable day. Aww. And like from that moment on, Roxanne, I mean, you remind me, we had a great relationship, even though we didn't have the words, until the point where we were able to discharge the woman's child home. So maybe it's failure too.
Yeah,
we learn from that.
I think how often someone has been very generous in spirit with me when I fumbled because I was making an effort. And so, I think the least we can do from the health system's perspective is afford them the same. They're making an effort. And so to try to give the space and be generous about it really goes a long way. I was lecturing to a group of beginning nursing students a few weeks ago, and one of them asked me a question about how I relate to. They asked two questions, but they were similar. One was how I relate to people who are very different than me. One question is because they wanted to know how I talk to all of my average age patient is 80. And to them, I look young. So let's say I'm very, very young. And then another question was about racial background. How do I relate to people? And that stuck with me. It's just sort of an interesting thing from someone beginning the profession. And I can hear this is something that's been on their minds as well. And so I'm just sort of scratching my head. I thought, it's a human connection. I can't not all the patients on my panel as their primary care provider are going to be like me. Even if they look like me, they're not going to be like me. And we all have to sort of figure out ways to make but we're all human, right? So what's the human connection? What's the tie? In primary care, what I love about it is that it's a relationship. I'm going to see this person again. And so, maybe I fumbled the last time and that's what they remember, or maybe there's always something I'm taking away from that last meeting that I'm bringing forward into the next meeting. Like I pay attention to them, I'm hearing them, and not rocket science, like I respect them. So how does it come across that you respect someone? Well, you actually respect them. It becomes, I think, pretty apparent in your interactions. I'm curious about some of your interactions with immigrant patient populations and some good or bad, or just how those encounters have gone. How do you make that human connection?
Are you talking to all of us, or?
Yeah, whoever wants to jump on it.
I remember I worked at a hospital that had a local IRC.
What is it?
Cool.
Come
I'm
on.
gonna need some help with this.
International Rescue Committee. I'll put another $1 in.
No, but IRC you were explaining it. It was okay.
That's okay? Oh, all right. I'll take that $1 back then. Great. The International Rescue Committee, IRC, and they brought families from around the globe at different times of the year into our community. And I remember at one point, maybe 5 or 10 families from Colombia had been brought. And I remember a mom brought her child in who was covered in this rash to our emergency department. And the mom was really freaking out. We had an interpreter and we sat with her, and her child was fine. It was a contact dermatitis, which basically is just like a reaction to a chemical or something like that, but not a dangerous chemical. It was going to go away. So we talked to mom. We gave the child some Benadryl. The child felt better. We sent the mom home. The next day, another mom came with a child with the same problem. The next day, another mom came with a different child, same problem, different moms, but all from Colombia. And we started asking, oh, did you recently move here? Welcome, yada, yada, yada. And it turns out all of those moms went to Walmart on like one of their first or second days there. And they were brought in by someone who didn't speak a lot of Spanish, but was helping them shop to get goods. And they all bought a whole ton of Tide detergent because the person guiding them through was like, Tide is really good. It'll clean your clothes. All these moms started using Tide on their kids' clothes. They'd never used Tide before. And all of these kids had this massive contact dermatitis. And like, it finally got to the point where moms started to come in and we'd see them at triage and we'd be like, do you know so-and-so? Do you know what, you ever heard of Walmart? Oh, yeah, you got it. And we would actually send them back home. So there were no extra charges, and moms would leave laughing. And like, this sort of shared education that we learned as providers. So we got in closer contact with the IRC, and they would give us a heads up when more families were coming. We would learn where they were coming from, and we were sort of primed to address some of these things. And most importantly, try to relieve some stress. Like, it's scary to come into an emergency room with your child. And I can't imagine how even more scary if you don't speak the language or in your new country. So a lot of cultural humility.
Yeah, absolutely.
And I think that our school has done great, with the Lillian Carter Center for Global Health and Social Responsibility. I don't know if everyone's heard of that, but I, as a student, got a chance to go on one of the alternative spring break trips. And I think it was one of the times where my eyes were really open to just how different experiences are in other countries. And not so much that what I learned about that experience, it's not so much about me going down there to help a group. There were things that were taught to me about health and what it means to actually provide healthcare. And I learned so much from the people in Jamaica that it really changed how I looked at nursing and what the role is. And Roxanne, I was going to ask you for students. I know you've navigated on the U.S. side as a student. What is it that students you think could bring to the table? We have a lot of immigrant students in our school. What is it that you think that students could bring to this healthcare conversation, or how can we better provide education to them and vice versa?
Yeah, so I don't know if you've heard of the Latin American Association here in Georgia. They are putting on this Latino Youth Leadership Conference and at Emory University, and Emory is hosting it. And the School of Nursing has now gotten involved to try to expose them to the profession of nursing to high schoolers, because oftentimes these kids are the ones who are interpreting for their families. They're like reading documents to their parents. And so I think that nursing students, Hispanic nursing students, kind of bring that cultural aspect to it, where they know what things will work and will not work. So for example, in our research studies with agricultural workers, early on in the beginning, before I was a part of the team, the recommendation for many of the agricultural workers who were overweight was to go and exercise for 30 minutes after they were done working, right? And it's like,
is that really going to happen?
Is that really going to happen? They've been actually pretty much exercising all day, right?
Yeah.
Like 8 hours. To tell them that just because it's a recommendation, like it's not appropriate. It's not culturally appropriate. It doesn't help them. But as a Hispanic person, I'm able to talk to them about their diet and what they eat. And I like to eat everything that they eat. So very heavy on carbs and starch. And so we have a discussion about that in a very like non-judgmental way and kind of fun way. And I think that that's what some of the nursing students can do, really kind of engage in the community in a very like intimate manner.
Yeah, I would love to just sit down and have more conversations about it. I mean, just learning more from just natural conversation. You know, where you come from and how does that inform health? I think that'll be a way that we can really kind of improve outcomes for certain groups.
Yeah, and thinking from the student perspective, I have a past student named Ren Kapukau who is now completing his PhD and probably will wrap it up in a year in nurse history. Ren's mom immigrated to the US from the Philippines, and Ren is doing his entire dissertation on looking at the history of immigration of Filipino and Filipina nurses coming to the US. And it's fascinating because he asked this question in his own work. He's like, growing up with other kids who were first generation, their parents encouraged them to be doctors, lawyers, and things like that. But he said he looked around and all of his Filipino friends were all on track to be nurses. And he finally asked his mom one day, "Mom, how come all of us from the Philippines are nurses?" And that inspired his research. And there's a really profound migration to the US and also, I believe, the UAE, United Arab Emirates, of nurses from the Philippines. And so like understanding that it's literally been tidal waves of people that have immigrated to this country to serve as nurses. We've got so much to learn. And I think about our newer students, our younger students. Yeah, how do we absorb that? And how do we change our practices based on what's real, not based on the way we've always done it?
Yeah. I think that something else that we, I don't hear it discussed very much, is that one of the things that is driving migration, is climate change. It's in many of these countries like Central America, and it's really hot and there's droughts, and people are not able to harvest, food and crops. And so they're hungry and they're emigrating because they need to survive. And I think we need to recognize how much climate change is affecting all of us. It's huge. I agree.
It's a lot of factors. That's why it makes me sad when I hear certain things where people have these, like they discriminate and they have these beliefs about certain groups that come here. And it's like, don't forget, like Tim, you brought up, this country was built on people coming here, right? So we shouldn't just isolate people and just act like they bring nothing to the table, and they shouldn't experience the discrimination. Like my mind has been shifting to COVID, for instance, and how Asian immigrants might feel right now. Are they receiving the care that they need? Or are people looking at them with, like, I don't want to take care of you. I mean, just because they have these stereotypes around, where the virus originated and all that. So I just really hope that we as a healthcare profession can be the example. I think nursing has always tried to be that example, but we, like you said, we have students at our fingertips. We have nurses who come from these countries and that have this wealth of knowledge that I just don't think we've tapped into very well. I mean, I think we do tap into it, but given the circumstances with COVID affecting certain populations more, I really think the answer is already there. We just have to dig for it.
Yeah. Same answer with resilience. If we think about folks that have come to this country and are working in this country, what many, many, many have been through to get to this place, the resilience that takes and has taken and continues to take. So all of this blah, blah, blah that I do about resilience and all this writing and academic work, I think can do a better job really tapping the true sources of resilience which are our immigrant communities and people in our immigrant communities who are practicing it every day and still thriving and innovating. I think we sometimes, no, not sometimes, our country's good at turning a blind eye when it wants to. And I think as leaders in our profession, we can help shift that, at least in our nursing profession, that we're not doing that as much.
Absolutely. These are our colleagues. These are our patients. These are our students. And so I'm glad we had some time today to talk about this important population and ways that we can support them. And I hope you've been inspired, those of you who've tuned in. I got the message in my ear, though. We've got to wrap up our conversation today. Any last words, guys?
Go out and vote.
And vote and vote. Yes. Thanks, everyone. Thanks for joining us. Again, we welcome your feedback. If you'd like to engage in ongoing conversation about this, check out the LinkedIn page for the Nurses Station show, where you'll see show notes and also can further the discussion. Follow us on all the social channels, Instagram, Facebook, Twitter, on Apple Podcasts, Spotify Podcasts. Until the next time, thanks, everyone.
Thank you.
Bye, y'all.
Bye.
Bye.
Bye.